Welcome to the presentation on antiarrhythmic drugs. We usually do not prescribe these in primary care, but many of our patients are on them, and you will need to look for side effects and toxicities. You also need to be aware of the many potential drug interactions before prescribing anything more. Antiarrhythmic drugs are used to treat a wide variety of heart rhythm disorders. These disorders include, but are not limited to, atrial fibrillation, atrial flutter, ventricular tachycardia, and ventricular fibrillation. There are multiple classification systems, but one classification, the Vaughan-Williams classification, has proved to be enduring. So this classification has 4 major classes, and then some people add a 5th one. I have listed the drugs under each, and we're going to talk about each of these classifications separately, and we are not going to be covering the drugs that are IV only. Class 1 drugs have a core common mode of action, namely they are sodium channel blockers. They decrease conduction velocity in the atria, ventricles, and his Purkinje system. Unlike the other antiarrhythmic drug classes, Class 1 medications are further subdivided into Class 1A, 1B, and 1C, depending on how the medicine impacts the length of the action potential. All of these classes are related to local anesthetics and have multiple drug interactions. Class 1A drugs are fast-channel sodium blockers. They slow impulse conduction in the atria, ventricles, and his Purkinje system. In addition, they delay repolarization at these sites, apparently by blocking potassium channels. So both actions contribute to the suppression of dysrhythmias. Examples of Class 1 drugs include disopyramide, quinidine, and procainamide. The mnemonic 1 double quarter pounder is often used to recall these medications. One is for Class 1, and double and quarter and pounder having the first letter as the above 3 medications. They are used to treat arrhythmias such as ventricular arrhythmias, prevention of paroxysmal recurrent atrial fibrillation, and some drugs such as procainamide are used to treat Wolff-Parkinson-White syndrome. Procainamide in the U.S. is by IV only, so we are not covering that. They all have anticholinergic-like effects, with tachycardia being a major side effect. Class 1B agents accelerate repolarization and have little or no effect on the EKG. Examples include lidocaine and mexiletine. Many of the antiarrhythmics have black box warnings, and some have several. Mexiletine has a black box warning indicating that it has been associated with increased risk for mortality when used to treat non-life-threatening arrhythmias. Thus, we don't see this drug much in primary care. The mnemonic lettuce and mayo is often used to recall these medicines, with each of the first letter of each word corresponding to the medicine's name. So far we have the total mnemonic for Class 1 is 1 double quarter pounder with lettuce and mayo. Class 1B antiarrhythmics are used to treat ventricular tachycardia, among other arrhythmias. They have fallen out of use, however, in the treatment and prevention of arrhythmias during or after a heart attack. Examples of Class 1C drugs include flecainide and propafenone. The mnemonic "and fries please" can be used to recall both medicines. Class 1C drugs should be avoided in coronary artery disease due to pro-dysrhythmic characteristics and increased mortality. They are used to treat arrhythmias such as paroxysmal atrial fibrillation and recurrent tachyarrhythmias, among other conditions. They are among the agents with the best evidence for cardioversion and may also be used for maintenance of sinus rhythm. Class 1C antiarrhythmics decrease cardiac contractility, so they shouldn't be used with beta blockers and non-dihydropyridine calcium channel blockers. Once shown safe in a monitored setting, patients can use at home to terminate atrial fibrillation, but they must be used with a beta blocker, diltiazem, or verapamil at least 30 minutes prior due to the risk of rapid ventricular response. Both of these drugs have multiple drug interactions. I do not expect you to know the particular enzyme systems, but that overall there are many drug interactions. Trough levels are required periodically, but I did not see where that was a timed event. Okay, Class 2 antiarrhythmics. Examples of Class 2 drugs include the beta blockers, all of which end in the LOL. For example, acebutol, esmolol, propanolol, and sotalol. Beta blockers block the effects of catecholamines, or epinephrine and norepinephrine, on beta-1 receptors, reducing sympathetic activity to the heart. They are highly effective at treating supraventricular tachycardias, decreasing conduction via the AV node. Since we have covered beta blockers previously, I'm not spending much time on them. Examples of Class 3 drugs include amiodarone, sotalol, dofetilide, and dronedarone. Class 3 drugs work as potassium channel blockers, prolonging the repolarization phase. They are used for ventricular tachycardias and atrial fibrillation. Conduction velocity is not decreased because they don't affect the sodium channels. However, sotalol also has beta blocker activity. Okay, so sotalol, it's a beta blocker that also delays repolarization, thereby prolonging the QT interval. It has a combined Class 2 and Class 3 antidysrhythmic properties. Although it's a beta blocker, it's not indicated for typical beta blocker use. It is indicated for life-threatening ventricular dysrhythmias and for rhythm control of atrial fib or atrial flutter, but not cardioversion. It is contraindicated in heart failure, bradycardia, second and third degree heart blocks. Sotalol needs renal dosing, and the potassium, magnesium, and renal function must be checked periodically. A black box warning emphasizes the risk of torsades de pointes from QT prolongation. Inpatient initiation is recommended to monitor for QT prolongation and pro-arrhythmic effects. Amiodarone is more complex. It has Class 3 activity, but it mostly acts via mechanisms like Class 1, 2, and 4, so it's got like everything. But serious toxicities can occur in the lungs, including hypersensitivity pneumonitis, interstitial and alveolar pneumonitis, pulmonary fibrosis, and that can be lethal. But the drug can also be cardiotoxic, thyrotoxic, and hepatotoxic. Because of toxicity, amiodarone is approved only for life-threatening ventricular dysrhythmias that have been refractory to safer agents. Amiodarone has hundreds of interactions and a plethora of side effects, but because of its efficacy, amiodarone is one of our most frequently prescribed antidysrhythmic drugs, and it can be used for atrial and ventricular rhythms, but it's pretty much off-label for AFib. It's not the first line. Explain that about half of all amiodarone patients have side effects, such as fatigue, tremor, or nausea. Amiodarone has very significant drug interactions, which may increase blood levels and promote toxicity. It's contraindicated in heart failure and has additive effects with beta blockers and non-dihydropyridine calcium channel blockers. Its half-life is between 25 and 110 days, which means toxicity can develop for several weeks after the drug's been discontinued. Amiodarone needs extensive monitoring. The liver function tests need to be tested at baseline and every 6 months. Transaminases can elevate in about 15 to 30% of patients, but usually they do not develop hepatitis and cirrhosis. That occurs in less than 3% of patients. But if you suspect hepatotoxicity, it must be discontinued. Pulmonary function tests, they need to have chest x-ray at baseline and yearly, and then the baseline pulmonary function test itself, including this diffusing capacity of the lung for carbon monoxide, which I've never heard about. And you repeat it if pulmonary toxicity is suspected, and you would know that if they had unexplained cough or dyspnea or an abnormal chest x-ray. Pulmonary toxicity occurs in about 2% of patients and may occur as early as 2 weeks into treatment. And as I already said, it's potentially fatal. EKG baseline and when clinically indicated, amiodarone causes bradycardia in about 5% of patients and can actually cause torsades de pointes in less than 1% of patients. Thyroid function at baseline, the TSH free T4 in total or free T3, and then TSH every 6 months. The incidence of hyperthyroidism may be as high as 12%. The incidence of hypothyroidism may be as high as 22%. The hyperthyroidism is obvious more common, but the hyperthyroidism is more dangerous. Eye exam at baseline and the event of visual changes. And as a primary care provider, you probably won't be ordering this routine monitoring, but you may see the patient as some of these toxicities develop, and you need to be aware of them. Now, after I have read all this, I don't know why I would ever want to be put on amiodarone. Dofetilide blocks cardiac potassium channels and delays repolarization, prolonging the QT interval. Initial treatment begins in the hospital environment. It's indicated for atrial fibrillation and flutter and is among agents with the best evidence for cardioversion. The black box warning emphasizes the risk of QT prolongation and torsades de pointes. The potassium-depleting diuretics may increase the risk by causing hypokalemia or hypomagnesemia. Ensure potassium levels are normal. Avoid other drugs that prolong the QT interval. And it is contraindicated if the baseline QT is greater than 440 milliseconds. It requires renal dose adjustment. and that is there are some interactions with renal cation pumps. So drugs that inhibit dofetalide's renal elimination are contraindicated, and I have listed some of them here. Dronedarone blocks potassium and sodium channels, beta receptors, and calcium channels. So it does many things. It prolongs the QT and PR intervals and widens the QRS. It was designed to be less toxic, but unfortunately it's also less effective than amiodarone with a shorter half-life. It is used for atrial flutter and paroxysmal or persistent atrial fibrillation, but not permanent atrial fibrillation. I find that interesting that they discriminate by that. It does have a black box warning that states increased risk of death, stroke, and heart failure in patients with decompensated heart failure or permanent atrial fibrillation. Dronedarone is one of the drugs that's better absorbed with food. The most common adverse effects are diarrhea, weakness, nausea, and skin reactions. Again, it is less toxic and less effective than amiodarone with a shorter half-life. Some drug interactions, there's a lot of them. Digoxin, calcium channel blockers, beta blockers, grapefruit juice, statins, and warfarin. Okay, Class 4 antiarrhythmics. Examples of Class 4 drugs include verapamil and diltiazem. Both drugs work as calcium channel blockers. They are both non-dihydropyridine drugs. They work to decrease conduction via the AV node. They also reduce duration of phase 2, which is the plateau phase of the cardiac action potential, and that results in reduced contractility of the heart, meaning both medicines are often avoided in heart failure. They are used to prevent paroxysmal supraventricular tachycardia and to reduce ventricular rate in patients with atrial fibrillation, among other conditions. Some resources have added a fifth class, or they're labeled as other antiarrhythmics. We will not be covering adenosine. Digoxin inhibits sodium and potassium ATPase, which allows more calcium to be available in the intracellular compartment. The end result is an increase in the force of myocardial contraction, which is a positive inotropic effect, a decrease in the heart rate, which is a negative chronotropic effect, and a decrease in AV conduction, which is a negative dromotropic effect. However, in the Purkinje and ventricular cells, it decreases the refractory period, which increases ventricular arrhythmias, and it increases automaticity, and that also increases the number of ventricular dysrhythmias. Digoxin now is a second-line treatment for heart failure. It's also used to treat atrial fibrillation and flutter and supraventricular tachycardia. Digoxin is a paradoxical drug due to its very narrow therapeutic index. It is an effective anti-dysrhythmia and also a potential pro-dysrhythmic agent. While the official upper limit of the therapeutic range is 2 nanograms per milliliter, there is some evidence to suggest that mortality in heart failure is improved at levels of 0.5 to 0.8 nanograms per milliliter, although others suggest that 1 to 2 nanograms per milliliter is an appropriate therapeutic range. Adverse effects include cardiac dysrhythmias, headache, hypotension, GI symptoms, blurred vision, and yellow-green halos. Causes of digoxin toxicity include decreased renal function, dehydration, electrolyte imbalances, myocardial ischemia, acidosis, and medication interactions. The signs and symptoms of digoxin toxicity are listed. Some of them are quite unusual and particular to digoxin, especially the change in color perception, the yellow-green colors and yellow-green halos, seeing bright lights. There are multiple EKG and rhythm changes that are listed, of which some can be fatal. And if you are suspecting dig toxicity, the patient must be sent to the ER where they will be treated. Antiarrhythmic drugs are a complex set of medications. Drugs have been categorized into 4 distinct classes. Many drugs have overlapping mechanisms of action. There is no one neat and simple classification, but the von Williams classification is widespread and accepted. Most have major, and I repeat, major drug interactions. Class 3 are used most frequently, but have the most toxicities. Thank you for your time and attention.